Hello everyone, Dr. Alex Vasquez here with video number 2 in this series on cardio nutrition. Today I'm going to talk about structural and functional importance of urinary alkalinization against mild metabolic acidosis. Today I'm going to start by reviewing the following articles, 3 of which are new, and the 4th is one that I introduced in cardio nutrition number 1, and I'm going to discuss that in more detail today. First, of course, we want to start by defining what it is we're talking about. And the topic today, as I've already mentioned, is metabolic acidosis. And here I'm going to talk about subtypes per cause and severity. These divisions and categorizations are my own ways of thinking about this situation, but I still think that it's clinically relevant. Even though these terms and nomenclature are not necessarily official, we just look at things here from kind of a common sense perspective. So when we talk about metabolic acidosis, we all, of course, appreciate that in some cases metabolic acidosis can be very severe. The context here is a very complex condition and major deviation from normal physiology, which is always resultant from a serious cause, and that cause itself must be treated directly while other resuscitative interventions are applied. Severe metabolic acidosis is characterized by decreased blood bicarbonate levels with blood acidemia, also reduced carbon dioxide secondary to the compensatory hyperventilation. This is typically divided into increased or normal anion gap acidosis. Typical causes include diabetic ketoacidosis, lactic, alcoholic, and poisoning acidosis, uremia, and renal tubular acidosis. Severe metabolic acidosis needs to be treated in the emergency department and is generally then followed by hospital admission. Category number 2 here is a more moderate level of metabolic acidosis. We see this in patients with renal insufficiency or overt renal failure. Treatment interventions can include administration of alkali, supportive medical care up to dialysis, and functional nutritional interventions to restore renal function. I've discussed that in my books now for about 10 years, and that information is also updated in the most recent version of Inflammation Mastery. Next, let's talk about mild metabolic acidosis. This is typically diet-induced metabolic acidosis and is extremely common, characterized by a urine pH of approximately 6.5, and the treatment here is diet modification and as-needed administration of citrate and bicarbonate. I think that we could also look at a 4th category of metabolic acidosis relative to excretory needs in patients who have been acutely poisoned. This was discussed in a landmark publication by Proudfoot and co-authors published in Journal of Toxicology and Clinical Toxicology in 2004. I'll talk more about that position paper during this presentation, but the clinical context here is acute poisoning, typically in a hospital setting. The specifically recommended treatment for alkalinization in this setting is intravenous sodium bicarbonate. But I'd also like to state here that a reasonable argument can be made that we're all poisoned with various chemicals and pesticides, and that therefore urinary alkalinization probably has therapeutic and preventive medicine benefits for just about the entire population. Also, a 5th category here, we could say relative functional or therapeutic preventive intervention with urinary alkalinization might also be used for the prevention and treatment of addiction, osteoporosis, insulin resistance, renal deterioration, and renal stones, nephrolithiasis, also sarcopenia. I'll talk more about those again during this presentation. And the treatment here would be same as number 3, which is diet modification and the as-needed administration of citrate or bicarbonate to reach a urine pH, let's say, of at least 6.5 and perhaps 7.5 or even higher than that. Again, I'll give you more details as we go through today. So let's talk about why this is important. Let's look at some clinical applications specific to disease treatment and prevention. The take-home message here is that urine alkalinization has many effects by several mechanisms to improve various systems, and together this promotes beneficial clinical outcomes. So let's look at number 1, osteoporosis, and I've given you some footnotes here to kind of help you connect the dots. I'll show you that in just a moment. But osteoporosis has been shown to benefit from urinary alkalinization, as has insulin resistance, hypertension, hypercortisolemia, renal deterioration, and urate and oxalate nephrolithiasis. Urinary alkalinization also lowers serum uric acid, thereby alleviating insulin resistance and hypertension. It also helps to prevent or alleviate sarcopenia due to diminished appetite and also glutamine catabolism. At least one study has shown that urinary alkalinization helps to alleviate the cravings that lead to addiction. Also, urinary alkalinization has been shown in at least one or two clinical studies to alleviate chronic pain. Also helps to alleviate diminished appetite. And some of these particular benefits might be due to low dopamine or catecholamine levels, which are increased following urinary alkalinization. Also, endorphin levels are increased following urinary alkalinization. Urinary alkalinization also helps to prevent and treat magnesium deficiency, and of course that provides us with a myriad of various clinical benefits. Again, I've detailed all of this in my book, Inflammation Mastery, 4th edition. The first section of that book was also published in a separate volume called Textbook of Clinical Nutrition and Functional Medicine, in that case, volume number 1. But again, the take-home message here, if you look at the 12 different items that I've listed here, is that urine alkalinization has many effects by several mechanisms to improve various systems and promote beneficial clinical outcomes. And I'm sure you'll agree that this is relevant to a lot of conditions that we see routinely, if not daily, in clinical practice. So now let's dive into the review of those 4 specific articles that I listed previously. We're going to start right now looking at this article, Luminal Alkalinization Attenuates Proteinuria-Induced Oxidative Damage in Proximal Tubular Cells. You can see this was published in the Journal of the American Society of Nephrology in 2011. This is an in vitro study with proximal tubular cells, and it was followed by a mouse study. Some of the key points of clinical relevance include researchers found that in the setting of proteinuria, and that is protein loss by the kidneys, acidic urine leads to the enhancement of oxygen-free radical production, specifically superoxide free radical, by renal cells, specifically via the following mechanism, and that is proteinuria plus acidic urine leads to phosphorylation of the intracellular pH sensor called PYK2 or PYK2, and this quickly leads to activation of NADPH oxidase, which produces the superoxide free radical. The authors go on to state, sodium bicarbonate feeding selectively alkalized the urine and dramatically attenuated the accumulation of superoxide-induced DNA damage and proximal tubular injury. Overall, these observations suggest that luminal acidity aggravates proteinuria-induced tubular damage, and that modification of this acidic environment may hold potential as a therapeutic target for proteinuric kidney disease. Before moving on to the next article, let's take a look at this article itself and also look at one of the diagrams, which I think really helps to explain what's going on in the kidneys when they're faced with a chronically acidic environment. So as you can see here from the first page of the article, the last line in the abstract states, overall, these observations suggest that luminal acidity aggravates proteinuria-induced tubular damage. So basically what that means is that the acidic environment of the kidney, if the kidney doesn't have enough alkaline reserve, we might say, this leads to accelerated renal degeneration, or we might say rapid biological aging of the kidneys. Also, looking in the first paragraph of this article on the first page, we see that reactive oxygen species are abundantly generated in the proximal tubular cells through the reabsorption of urinary albumin. So again, when protein is excreted from the kidneys, the reabsorption of that protein induces the formation of damaging oxygen-free radicals, specifically superoxide. And the authors provide a bit more detail by stating, subsequently, these receptor albumin complexes activate protein kinase C signaling pathways, which leads to NADPH oxidase-mediated free radical generation. Now let's look at an image from this article, which I think is very clear in its depiction of the pathways involved and also the clinical implications of those pathways. Here, the authors provide more explanation of the intracellular signaling mechanisms involved in this albuminuria-induced superoxide production, again, in renal proximal tubular cells. And look at what they state following. They state, proteinuria associated with physiological lumen acidification cooperatively induces robust PYK2 activation in proximal tubular cells. The activated PYK2 induces extensive ROS accumulation through activation of, ultimately, NADPH oxidase, which produces the superoxide free radical. Now let's move on to the next article. The next article is titled, Bicarbonate Supplementation Slows Progression of Chronic Kidney Disease and improves nutritional status. You can see this was published again in the Journal of the American Society of Nephrology, 2009. This is a randomized clinical trial involving 134 patients with chronic kidney disease with a creatinine clearance of between 15 and 30 milliliters per minute. So this is pretty major kidney disease at this level. This is stage 4 kidney disease. These patients need to be managed by a nephrologist or internal medicine specialist. And in this study, they were treated with sodium bicarbonate for a period of 2 years. Key points of clinical relevance here: the decline in creatinine clearance was slower with bicarbonate supplementation. So again, alkalinization is helping to preserve kidney function. Patients supplemented with bicarbonate were significantly less likely to experience rapid progression to end-stage renal disease. This was 9% in the bicarbonate group versus 45% in the untreated group. Again, here the authors state, similarly, fewer patients supplemented with bicarbonate developed end-stage renal disease, 6.5% versus 33%. Obviously, that's a very huge difference. Nutritional parameters improved significantly. This included improved food intake, better muscle and fat mass, increased arm circumference, increased serum albumin, which may have been due to the improved food intake and also due to reduced catabolism of glutamine for urine alkalinization. Toward the end of the article, the authors conclude the importance of an optimum acid-base status for positive clinical outcomes and survival has been acknowledged by kidney disease outcome quality initiatives and the European Renal Nutrition Consensus that recommends maintaining a serum or plasma bicarbonate level of at least 22 millimoles per liter. Again, before leaving this article, we'll take a look at the first page of it. Bicarbonate supplementation slows progression of chronic kidney disease and improves nutritional status. Again, this was published in a major nephrology journal in 2009. I'll read to you some of my highlights here. Bicarbonate supplementation slows the rate of progression of renal failure to end-stage renal disease and improves nutritional status among patients with chronic kidney disease. Let's look at the first paragraph, which states, metabolic acidosis, generally perceived by clinicians as a low plasma bicarbonate, particularly when the GFR falls below 30 milliliters per minute. This, in turn, may bring about a variety of sequelae, such as stunted growth in children, loss of bone and muscle mass, negative nitrogen balance, and the possible acceleration of the progression of chronic kidney disease. Again, they notice that metabolic acidosis contributes to protein energy wasting in patients with chronic kidney disease. They also state that acidosis is associated with increased protein catabolism as a result of the upregulation of the ubiquitin proteasome system, excessive oxidation of branched-chain amino acids, and reduced synthesis of visceral proteins, including albumin. Several small short-term clinical trials, mainly of dialysis patients, suggest that correction of acidosis is associated with increased serum albumin, a reduction in normalized protein catabolic rate, and an increased concentration of total essential amino acids. So again, I think a lot of people will be interested to learn that pH affects nitrogen metabolism globally and specifically amino acid metabolism, which can have catabolic effects in patients who have chronic metabolic acidosis. Let's move on now to the third article in this review. This article is titled, Alkalizer Administration Improves Renal Function in Hyperuricemia Associated with Obesity. This was published in the Japanese Clinical Medicine Journal in 2013. The structure of this study is that of a study involving 31 hyperuricemic obese patients randomized to receive allopurinol therapy to reduce their serum uric acid levels or allopurinol plus citrate, which was called combination therapy. The key points of clinical relevance in this study include hyperuricemia causes the deposition of uric acid crystals in glomeruli, which in turn induces inflammation of the renal parenchyma, thereby leading to renal dysfunction. So obviously this becomes a vicious cycle. Patients with elevated levels of uric acid in their blood are depositing crystals in their kidneys, which causes kidney damage. The reduced kidney function then leads again to higher levels of uric acid, and it just becomes a vicious cycle of elevated uric acid leading to kidney damage, and that kidney damage reduces the kidney's ability to filter out the uric acid, leading to more uric acid, which leads to more crystallization and therefore more damage, again in a vicious cycle. For this study, they administered citric acid in the form of sodium citrate and potassium citrate. And what they found is that because of that citric acid supplementation, urine pH significantly increased from 5.7, which is quite acidic, to 6.2, which many of us would still consider to be acidic, but it still helped to preserve renal function, and that's one of the main points that I want to make today. Alleviating the excess burden of diet-induced metabolic acidosis, even if it's imperfect, still leads to significant improvement in long-term clinical outcomes. So we see a lot of patients in clinical practice who have a urine pH, let's say, of 5.5. Those patients are losing renal function due to the acidity of their urine through mechanisms I've already discussed, namely the increased generation of oxygen-free radicals within the kidney due to the acidic environment. If we can get those patients from severely acidic to mildly acidic, we're still improving their clinical outcomes in the long term, even though they're still acidic by my standards, and I'll justify those later in today's presentation. I've already talked about this now for about 10 years in my books, most recently in Inflammation Mastery, now in its 4th edition. But let's take a look at a few more details from this study, and I think this will help you become convinced of the importance of urinary alkalinization. So let's look at some excerpts from this article. The discussion of this article states, obesity is involved in the onset and progression of diabetic nephropathy, hypertensive nephropathy, and chronic kidney disease due to glomerulosclerosis. All of these complications are closely associated with hyperuricemia. Some of you may recall a study that I reviewed a few years ago showing that hyperuricemia itself, which can be induced dietarily through the consumption of high fructose corn syrup, hyperuricemia itself causes insulin resistance and hypertension. They go on to state that hyperuricemia, like obesity, is a risk factor for exacerbating renal impairment, and it is necessary to prevent the progression of renal impairment by treating the hyperuricemia along with the obesity. So in other words, we might say that when you see a patient who's obese and you're trying to treat that aspect of their total health matrix, you need to consider not simply the obesity and the hypertension, which are rather obvious clinically, but also the urine acidification and the metabolic acidosis. Alkalinization reportedly lessens oxidative injury of proximal renal tubules and slows the progression of chronic kidney disease. Alkalinization also improves renal impairment in patients with hypertensive nephrosis. In the second column on this page, you'll also see that the authors note that urine alkalinization has also been reported to suppress increases in visceral fat. So how could urine pH affect visceral fat deposition? And again, I think the most obvious mechanical answer, if we had to pick one answer, or say the best answer on a multiple choice exam, the best answer would be that urine alkalinization promotes excretion of uric acid, and that helps to alleviate insulin resistance, that helps to lower insulin levels, and that helps to reduce de novo lipogenesis, which leads commonly to deposition of adipose tissue within viscera. And that increased fat deposition in organs is exactly what we see, for example, in non-alcoholic fatty liver disease. Finally, from this page, the authors state, alkalinization has been shown to provide protection against injury to renal epithelial cells, which occurs via crystallization of oxalic acid and calcium oxalate in the renal tubular lumen in patients with renal calculi, also prevent chronic kidney disease progression and improve renal function in polycystic kidney disease. Note what they just said there, improve renal function. We don't have a lot of treatments that improve renal function, but urinary alkalinization clearly is one of the treatments that has the most supporting data. Let's look at some more information from that study, and especially in table number 2 of this article, which describes changes in serum uric acid before and after treatment with alkalinization. So basically, what you see as a result of intervention with citric acid in this study is that serum uric acid levels decreased to a greater degree with citrate therapy than simply with allopurinol by itself. So all of these patients received allopurinol, which is a drug that blocks the enzyme that produces uric acid. But what the study emphasizes is that the administration of citric acid helps to reduce serum uric acid levels to a greater degree than allopurinol by itself. So you'll see in the final paragraph on that page, in conclusion, the present study clearly demonstrates that the use of citrate combined with allopurinol raised creatinine clearance, which means it improved kidney function and also decreased serum uric acid levels. Furthermore, allopurinol and citrate combination treatment might be useful for improving blood triglyceride profiles in obese patients with hyperuricemia. Again, uric acid appears to promote insulin resistance, so lowering uric acid levels by the administration of citrate to improve uric acid excretion by the kidneys helps to reduce insulin resistance, and that helps to improve the blood triglyceride profile in these patients with obesity and hyperuricemia. Now let's look at article number 4 in today's review. This is the last article that I'm going to review. Empiric use of potassium citrate reduces kidney stone incidence with the ketogenic diet. This was published in Pediatrics in 2009. And again, I introduced this article in Cardio Nutrition video number 1. This study included the administration of potassium citrate, 2 milliequivalents per kilogram per day in children on the ketogenic diet for refractory epilepsy. The key points of clinical relevance include potassium citrate was administered to 198 children preventatively overall, of whom 2% developed kidney stones compared to 10% who did not receive potassium citrate. So very clearly that shows that potassium citrate helps to prevent kidney stones in patients taking a ketogenic diet. Very interestingly, the authors note that potassium citrate resulted in less acidic urine, and that is, it was 6.8 instead of 6.2, which is still quite acidic, but this did not reduce serum acidosis. So what that shows you is that the buffering reserve remains depleted systemically even when the urine pH is at 6.8. Well, what does that tell you about the many patients that we have who have a urine pH of 5.5 or even 6.5? That shows you that they are depleted in terms of their buffering reserve to manage their acid-base balance. They're in a chronic state of mild metabolic acidosis. Now I'm going to show you 2 very important excerpts from this article. Number 1, oral potassium citrate is an effective preventative supplement against kidney stones in children receiving the ketogenic diet, achieving its goal of urine alkalinization. Universal supplementation is warranted. That's a very strong statement coming from a major medical journal. Universal supplementation is warranted. Now let's look at the final sentences of this article, which state, "We strongly believe that the universal use of potassium citrate is warranted in all children starting the ketogenic diet, with clear benefits outweighing risks. We advise initial education about the importance of regular potassium citrate use at the time of ketogenic diet onset, or the implementation of that diet, and subsequent reinforcement at each follow-up clinic. Further studies may help determine if higher doses of potassium citrate would be completely preventative or could perhaps be combined with other supplements such as multivitamins to aid compliance." Again, that's a very powerful statement coming from a major pediatric medical journal. Again, this was published in Pediatrics, the official journal of the American Academy of Pediatrics. This was published in 2009, and the conclusion states, "Oral potassium citrate is an effective preventive supplement against kidney stones in children who receive the ketogenic diet, achieving its goal of urine alkalinization." And then they specifically emphasize, universal supplementation is warranted. Again, this is a very powerful statement. This isn't simply a recommendation. It's not simply showing good benefit. They're stating that this should be the standard of care. Universal supplementation is warranted. Again, published in the journal Pediatrics by the American Academy of Pediatrics in 2009. Now, to conclude today's video, I want to remind you of this information, which I reviewed in Cardio Nutrition video number 1, and that is the potassium target intake for adults is 4.7 grams of potassium per day. 90% of adult patients in the United States, for example, do not achieve that level of intake. Typically, they're deficient by 25 to 50%, which means they need to supplement 1 to 2 grams per day of potassium. I also showed you in the previous video what's been demonstrated in many of the clinical studies in terms of dosages. So now let's look at the clinical take-home of all of this information so that we all know what we need to emphasize. From article number 1, what we concluded is that alkalinization protects the kidneys, at least in this experimental model. In experimental proteinuria, acidic urine enhances superoxide production by renal cells, leading to DNA and cellular damage and accelerated renal aging or degeneration. So again, alkalinization helps to protect kidney cells by reducing free radical damage. In the second study, the conclusion here is that alkalinization helps protect the kidneys not simply experimentally but also clinically in humans. In patients with chronic kidney disease stage 4, alkalinization helps preserve renal function while also improving nutritional status, that is specifically food intake, lean muscle mass, total mass, and serum albumin. We also noted specifically that serum or plasma bicarbonate in these patients should be at least 22 millimoles per liter. And for the third study that I reviewed for the first time in today's video, Alkalinization protects kidneys and reduces serum urate levels. In obese hyperuricemic patients treated with allopurinol, the addition of citrate for urinary alkalinization reduces deposition of uric acid crystals in the glomeruli, in turn reducing inflammation and preserving renal function. This occurs while reducing serum urate levels and improving metabolic health, even with only a relative alkalinization of the urine from 5.7 to 6.2. So again, 5.7 is very acidic, 6.2 is moderately acidic, but these patients are still acidic and they could actually use more alkalinization therapy, but even with moderate intervention, they still improved metabolically and clinically. So based on those conclusions, my recommended action is that clinicians and patients use potassium citrate for urine alkalinization, number 1, to reduce uric acid levels in the blood, number 2, to prevent urate and oxalate kidney stones, number 3, to preserve renal function, number 4, to promote various other benefits, which I'll review with you again before we finish today, and also, importantly, number 5, to increase potassium intake, because 90% of people do not consume enough potassium to reach the stated goal of 4.7 grams per day. And now that we've reached some of the last pages of today's presentation, I want to again emphasize some of the clinical concepts and implementation. Number 1, we see the need that people have for potassium. Again, 90% of adults fail to meet potassium intake of 4.7 grams per day. And the second need that we're trying to address here is that mild metabolic acidosis is extremely common and has numerous adverse consequences. So based on those two needs, number 1, that most people need more potassium, and number 2, a lot of patients, if not most patients, have mild metabolic acidosis, which has numerous adverse consequences, we establish certain goals, and those goals are specifically urinary alkalinization. Some authors suggest that urine pH needs to be at least 6.5 to be considered relatively alkaline, but given that urine pH of 6.8 is insufficient to reverse metabolic acidosis, then obviously a higher urine pH is warranted. Notice that in the internationally endorsed position paper by Proudfoot and co-authors in 2004, they advocated a urine pH of 7.5 in the setting of the treatment of acute poisoning. However, we also see that level of alkaline urine pH reflected naturally in the environment, especially in this study published in the American Journal of Clinical Nutrition 2002. They noted that among hunter-gatherer tribal groups, urine pH was typically between 7.5 and 9. So that's simply due to a hunter-gatherer diet and along with plenty of exercise, because of course, when people exercise, they hyperventilate. When they hyperventilate, they blow off carbon dioxide. That reduces their carbonic acid levels and makes them more alkaline. So it's the combination of a plant-based diet with exercise that helps people maintain a natural state of urinary alkalinization. However, we also know that a lot of patients, even if they consume a plant-based diet, they will still be metabolically acidotic, and therefore they need supplementation, again here, with potassium citrate. One form of potassium citrate available by prescription is called polycitric K. You can see by the description that each packet contains potassium citrate, but it also has some type of fruit flavoring, and I'm not exactly sure what that fruit flavoring is. I did try to look it up, of course, on the internet. I couldn't find any definition of what they were using for fruit flavoring. I'm presuming that it's some type of artificial chemical. And obviously we know that a lot of artificial colors and flavors have adverse effects, either through allergic mechanisms or through adverse effects on the microbiome. Another source for potassium citrate is called potassium HP, each teaspoon providing 1,200 milligrams of elemental potassium as potassium citrate, along with, for additional clinical benefit, 120 milligrams of elemental magnesium as magnesium citrate malate. This is produced from Biotics Research Corporation, and again, you can see the dosages that are provided here per scoop, which is approximately 1 teaspoon. This supplement provides magnesium as magnesium citrate malate, 120 milligrams, and potassium as potassium citrate, 1,200 milligrams. You'll also notice that the product does not contain any artificial colors, flavors, or gluten. So again, in summary, we see that urine alkalinization provides many clinical benefits by combating mild metabolic acidosis. This is clinically relevant for osteoporosis, insulin resistance, hypertension, hypercortisolemia, renal deterioration, and especially due to urate or oxalate nephrolithiasis. Urine alkalinization has been shown consistently to lower serum urate levels, and that's probably the mechanism by which it helps to alleviate insulin resistance and hypertension. Urine alkalinization also helps to alleviate or prevent sarcopenia due to diminished appetite and increased glutamine catabolism. Urine alkalinization also shows benefit in the treatment of addiction, chronic pain, diminished appetite, and those benefits might be due to low dopamine catecholamine levels as well as low endorphin levels. So one study in particular suggested or showed that urinary alkalinization or the supplementation with alkali helped to increase endorphin levels. That, of course, helps people to feel better, have less addictive tendencies, and reduced pain. Also, urinary alkalinization helps to promote retention of magnesium, and that provides many benefits in fatigue, heart failure, hypertension, muscle cramps, and bruxism, constipation, depression, anxiety, seizure, encephalopathy, and vitamin D deficiency by improving vitamin D metabolism with additional magnesium retention. Finally, I want everybody to remember that when patients enter chronic kidney disease stage 3 and have a creatinine clearance of less than 60, the management changes and more cautions are needed. I invite you to see my other video on that topic regarding the assessment and management of chronic kidney disease. You can find that on vimeo.com/Dr. Vasquez/renal. I also discuss that in detail in Chapter 1 of my book, Inflammation Mastery, 4th edition, also published separately as Textbook of Clinical Nutrition and Functional Medicine, Volume 1. So with those benefits and a few cautions in mind, that brings us to the conclusion of today's presentation. You can download a PDF transcript of today's presentation at ichnfm.org/18, also from my academia.edu page, which you can see here, ichnfm.academia.edu/Alex Vasquez. And again, I appreciate your attention today as we talked about cardio nutrition, part 2, emphasizing the structural and functional implications of urinary alkalinization therapy, specifically with potassium citrate.